We wish to acknowledge this land in which the Fields Institute operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And I will turn it over to Zhenhong Wu, our PI, to introduce our speaker today.
Thank you, Ben. Good day to all of you, and good evening to our distinguished speaker and our participant from the time zone sharing with Steve's time zone. And I'm very pleased to have Stephen Riley coming back to the Fields Institute. I don't think we need introduction of Stephen and Dr. Riley for the vast majority of the audience. We have been reading his pandemic modeling. We have been benefit from reading his very influential pandemic modeling from SARS-1 to pandemic influenza and to COVID-19 pandemic. Steve has been playing a major role in UK and globally in modeling those public health emergencies for many years, and it's been a major player, I believe, in UK in developing the model to inform decision making. Before I'm not so sure if, Steve, you're still holding faculty positions from Imperial College in London, but I do know you are directly played a major leadership role in the UK Health Agency data analytic and surveillance. One thing I find interesting is always very interesting is Steve had training from computer science, physics. And correct me if I'm wrong, Steve, to my knowledge, despite there are so many mathematical epidemiologists nowadays, you are the first to receive a PhD degree in mathematical epidemiology. So with that, Steve, time is for you now.
Thank you, Zhenhong. Yeah, that's for a very kind introduction. Even though it's only virtual, it's a pleasure to be back in Canada. I've not visited for a number of years, but I've got very fond memories of some meetings with members of with people who are on the line now, especially in Banff during the early 2000s after the SARS outbreak, where some of the ideas I'll talk about today were very much spoken about, and I can remember a few good discussions with people on the line. Yes, so I am still I am seconded into the UK Health Security Agency, and I'm still a professor of infectious disease dynamics at Imperial College, but with only a minor commitment there. And again, with apologies for being late due to some logistical issues, I'd like to spend well, over the next hour, I'd hopefully like to generate some good discussion and pick out just a few concepts from the use of disease dynamics for public health during the COVID-19 pandemic. This is not in any way intended to be a survey or a reflection. This is some personal reflections on work that I found interesting. I think it still is relevant and may not be as kind of widely known. So I'll talk. It'll be kind of some comments in three parts. And I will have two separate slide decks, so there'll be a little bit of changing around in the middle. So during the pandemic, I was part of the Imperial College COVID-19 response team, and we did a lot of infectious disease dynamics using mathematical models at the beginning of the pandemic, and I kind of worked with them throughout. We fed directly into the SPI-M committee, Scientific Pandemic Influenza Modeling Committee, which was part of the Department of Health and Social Care. And then in the kind of middle stages of the pandemic, a lot of my time was taken with the REACT study out of Imperial College, and I'll talk a little bit about that as well. And then the final part, I'll introduce the UK Health Security Agency and try and describe a little bit about how my team sit within that, and generally introduce the overall mission of that agency and talk about how the team is organized. Hopefully set up some questions and give ourselves a chance for a good discussion. I can see the chat. I will see things pinging up. So I know it's not really the convention these days, but if you do want to just open your mic and shout out or put something in chat as I go through, I certainly don't mind. But I will try not to talk completely through the next hour. So this the main section I'm going to split into 4 parts. Just give some general thoughts about like where we are now and how the use of infectious disease dynamics has played out during the pandemic and now into the current times. And then I'm going to do one case study from the very beginning of the pandemic about the decision of whether and when to impose stringent social distancing in the UK, and especially the degree to which very simple models did or didn't play a part, or could and could not explain some of the difficult choices that had to be made in some countries at the very beginning of the pandemic. The community transmission section is going to be mainly about React, and it'll be about some of the results from React just around the time that I transitioned into UKHSA, around the Delta plateau or the Delta takeoff, just to illustrate how, gathering how we can get better insight with some really precise, well-structured data. And then I'll have some future directions briefly at the end, just to try and motivate the discussion. Okay, so this is just now, and I'm sure you've seen a number of talks that start like this, just today, taken from Our World in Data, and it's the cumulative deaths from all causes as an excess compared to the projection, the baseline projection, expressed as a percentage, where you can see on the left-hand side of this chart, an awful lot of the variation is driven by the degree of excess mortality during the early waves of the pandemic. Obviously, we're now going into periods where there's less death than is on the projections, and I think the right-hand side of this chart are somewhat difficult to interpret because the baseline signal as you get further into the 2022 and 2023 is difficult to interpret for excess mortality, but it tells a pretty clear story. And this is something that for many years we did talk about, and when we had our pandemic preparedness and then the flu pandemic meetings, we always knew that in the event of a moderate or severe pandemic, that some countries would do much better than others in terms of all the different metrics, and that was certainly the case. So in very, very broad terms, every country now is in just about the same position. We have to reflect back from a point of view of public health or health security. We have to reflect back and look at how we did against different metrics, try and explain why some countries did better than others, think about the reasons that the decisions were taken. And then for us in our community, we have to look at how we were able to support decisions during the course of the pandemic using mathematics, infectious disease dynamics, and how that can be improved for next time. What are the important things that we need to do now? And I'd certainly call out from this talk is about the United Kingdom, and it certainly has a fairly extreme kind of initial trend on this chart for reasons that we'll talk about, and I'm sure many of you are familiar with. And I think for this group, I suspect many of you have implemented models that look a little bit like that could be described by the boxes at the top. This slide is just to highlight really the 2 aspects of what I'm describing as infectious disease dynamics. I appreciate this is specifically a mathematical network. I'm sure many of you use compartmental models and lots of other advanced analytical techniques probably as well to think about disease dynamics. The quantitative techniques, the analytical techniques that we use, is only half of what I call infectious disease dynamics. There's the empirical side of going out and gathering data, thinking about how people behave, trying to understand how they travel, why they make the contacts that they do. And this slide is just to highlight there's both the kind of the theoretical and the applied infectious disease dynamics. In between outbreaks and pandemics, there's a large community around the world engaged in both these types of science and bringing them together. And I think just what we would hope now, and we would have all hoped back in 2019 is that the combination of our of the work we've done, the results we've published, the methods and techniques that we have, did put us in a position to provide some kind of support for better policy and better action during events such as the COVID-19 pandemic. So then, just some reflections, and this very much is kind of my view as an academic, and certainly how I spent, as I said, up to October 2021 as a full-time member at Imperial College, feeding in to policy through advisory committees. It's only since October 2021 that I've joined the executive agency of UKHSA. So I think it's worth reflecting on how health policy and action works during an emergency. Firstly, the science itself and policy formulation are somewhat similar, and they're slightly adversarial. You can, I think, compare them to to criminal law, where there is an idea that through this adversarial process, the truth will come out. We try not to think about absolute truths in science or in policy, but we don't spend our time talking or worrying about things that are obvious. Something becomes a contentious issue during an outbreak because the science is not immediately conclusive, and either interpretation is difficult or more work needs to be done. So I think it's worth accepting that it's slightly, we should have expected it to be pretty adversarial, especially during outbreaks, and that hopefully during normal times it's much less adversarial when there isn't the same amount of time pressure. Things change really rapidly during an emergency. So the way that we look back at our work and then use our work to feed into analysis has to kind of take into account the rapidly changing stakes. So the seniority of the participants increases rapidly in the early stages of an outbreak and throughout as the stakes increase. And therefore the appetite for both opinion and evidence increases extremely rapidly during an emergency. It was an extreme example during the COVID-19 pandemic, but if we look back at SARS-1, the flu pandemic, Zika, Ebola, we can see very similar trends, and we certainly should not have been surprised by that. And then, it's not easy, and I think if you look around at the variation in policy decisions that were made in somewhat similar settings all around the world, and the variation in outcomes that some of which I've displayed in that first slide, it's very difficult to get perfect policy or very good policy during an emergency. It's even difficult, to define it after the fact. And just come back to my original point, the phase, even though COVID-19 was an extremely unusual event, we do go through a regular cycle of emergencies and then kind of inter-emergency time when we have the opportunities to learn and improve. Okay, so that was just a few kind of general comments about the science that I feel, the community I feel I'm part of, the type of work that we do, and how we think about it and thought about it setting up for the pandemic. And now I just want to think about like one particular case study that I was involved in that I think has still got relevance as we consider what optimal strategies might be going forwards. For example, there's a lot of interest in flu preparedness right now because of the changing ecology and evolutionary biology of H5N1. So a lot of countries are looking back to their flu preparedness plans, and I think it's interesting to look back at the beginning of COVID-19 and try to envisage exactly what would happen. Preparedness should not be around very, very narrow scenarios, or don't say that for a second, but I think it is an interesting question right now. If we got something that was very similar to SARS-CoV-2, but no existing immunity, so they're very similar dynamics, but a completely different immune profile, so it came as a new pathogen, I think there would still be tremendous variation in the policy that we had during the first few months of a very similar pandemic. So I think it's in that context that we need to look back at some of the early decisions in each of our different countries and think about how we would support those difficult decisions. So just to cast back, what now seems like, I'm sure to most of us, seems like a different lifetime. This is a photograph from the last few hours of the tube functioning in Wuhan. And I think the date is at the end of January. I think it might be the 25th. I haven't noted it on the slide, but it's one of the days at the end of January, as Wuhan went into lockdown. And that was, an utterly kind of momentous event at the time. It was unexpected, I would say, from having worked on pandemic preparedness for respiratory pathogens for a considerable period of time before the pandemic. I think it was essentially none of our planning really included that type of intervention. And at the time, my memory of the way WHO characterized it is that it was a very kind of speculative and unexpected thing to happen. But it immediately changed all the policy questions around the world from countries that were thinking about whether or not they would have to impose really stringent social distancing. And then I think this slide is taken from colleagues at Imperial, and it came out, about kind of 6 or 8 weeks after that slide there, and it represents, a very, I think, commonly held view at the time, and it also reflects an awful lot of work that many of us have been involved in the years prior to the COVID-19 pandemic, expressing the really substantial concern that people had about the use of stringent social distancing. So on this chart, this group will be very familiar with this type of analysis. The red line is an unmitigated pandemic. The green line is a kind of a mitigated but pandemic that would still cause herd immunity in a relatively short time. And the blue line was kind of what a lot of people thought might well happen, is that any kind of stringent social distancing would just delay a very similar epidemic and potentially lead to an even higher number of infections. So this is an example of, as I say, kind of a lot of expresses the substantial concern of many people at the time that there was very little benefit of encouraging any social distancing. And I think the one observation, so I'm going to go back to some very early work that I was involved in during the beginning of SARS-1, where we looked at different factors that influence the transmission of SARS in Hong Kong. And part of that work was trying to estimate the R0, look at the impact of particular super spreading events, and then we tried as much as we could to disentangle the reasons for the reduced transmissibility at the end, and we couldn't really explain exactly why transmissibility had dropped to only 37% of its original value, and then to 6% eventually at the end. There certainly wasn't herd immunity during SARS-1 in Hong Kong, and one of the hypotheses we had was that the people may have rapidly improved the speed with which they went to hospital. So by reducing the time in the community, that may have taken a lot of infectiousness out of the community and brought it down through public health messaging. And we tried to test that, and that couldn't explain that much at all. So without any other explanation, the conclusion that's in the paper is just to basically say, once people knew it was present and they were aware of the mode of transmission, then the behavior changed dramatically, and the population of Hong Kong, spontaneously through social distancing, essentially reduced the R value to very much below 1, and that's what contributed to the rapid fade out of SARS-1 in Hong Kong. And so this is from a government paper. It's not in a peer-reviewed paper. Some of the same points are made in the Imperial Report 9, but essentially, this is including an observation into those simple models, looking at the early transmission dynamics of SARS-CoV-2 in a population like the UK, doing some similar analysis to these curves here, but considering the possibility of spontaneous changes in behavior. So on the chart on the left is just a linear version of the log scale chart on the right. So if you start on the left-hand side, the red line is an unmitigated rapid epidemic. The blue line is kind of what the UK was nominally aiming at the time, which was trying to mitigate such that you just about hit herd immunity. I think this was based on we were thinking about an R of about 1.9 or 1.8 at this stage. So it's a simple calculation to figure out what's the absolutely ideal mitigation that would give you herd immunity, and in some idealized way give you this kind of perfectly flattened curve. Obviously, the first point on here which is included in this report, there's still a huge amount of disease and death under the blue line. It's astronomical in many ways. But the cyan line, the light blue line on the right hand side, might be the most kind of interesting. This examine the scenario where once you reach the capacity of intensive care in this kind of slightly idealized population, if there was a spontaneous reduction in the behavior, in the mixing of the population, what would, such that it had to drop below 1, what would that be? And it's not that much. It's only about a 30% additional spontaneous reduction in transmission, 30 or 40%, that would stop the epidemic growing if that occurred when ICUs were full in this idealized population. And on the log scale on the right, you then get this very simple dynamic. If you impose this constraint of the population changing their behavior when they bump up against the ICU unit, you get this kind of wiggly line bumbling around 1. And on a linear scale, that's an incredibly that is far lower than anything like the peak of the dark blue line. The green line on here is just a kind of an idealized view of sustained control over a long period of time. So the point that we were making here is that essentially it was very unlikely that any of those rapid epidemics were ever on the table as an option. That unless R0 is astronomically high for a respiratory virus, it's very likely that the reaction to the self-limiting change, the self-imposed changes in behavior do not have to be that extreme, that you're not going to have any kind of opportunity for a rapid epidemic. Therefore, you're kind of letting the characteristics of the virus and the behavior of the population take over and determine the pattern of the epidemic. And I think that if we now look around at many different countries that chose different paths at this point in time, there are countries that essentially did have trajectories somewhat similar to that cyan line, and countries were not. No country really had those very rapid epidemics, with the possible exception of some of the much younger countries, and there the data are difficult to identify. And then alongside that, just kind of briefly, as we were looking at some of these idealized models and the patterns in the UK, we're also tracking movement data from social media accounts in China, and you could see how if you compare the movement during 2020 in the dark blue lines with the movement during 2019 in the light blue lines, because it's happened around Lunar New Year. So you have to really compare them. So on the bottom row, we're looking at how those movement changes, and on the top, we're looking at the case counts. That as we were progressing through the same period of the very difficult choices in the West, you can see that the case counts in China were going down to really quite low levels, and that movement was returning. Even though they weren't going back to normal, they were recovering substantial levels of activity. So essentially, as we were having to make those very difficult decisions, that we were seeing evidence of a successful exit in inverted commas. Obviously, much time has passed since these first few weeks, and there's a whole different discussion about what optimal policy might have been in some of the countries that achieved early levels of containment, but I won't go into that And then the final point, again, really just coming back to this idea that the population is going to react as it's going to react. We can, the decision makers, policymakers, and scientists can influence what happens, but we certainly don't have complete control over it. And I think as we look down and as we look back and think about the decisions that were taken, and as we, feed into lessons learned and think about the options that would present going forwards, I think it's really important to have a two-stage process in our minds when we think about social distancing or lockdowns. That we know there's a really good link between the way that people behave and the transmissibility of respiratory viruses. That we've got overwhelming evidence of how the number of contacts that people have and where they have them determine the spread of those pathogens. We also know that mandates, legislation, and guidance affect the way that people behave, but it's not a perfect one-to-one correlation. We are not robots. We don't do exactly what we're told, and we don't do the opposite of what we're told. So decisions to impose policy are slightly separate from the discussion of how behavior change affects the transmission. And I think we need to really carefully keep that in mind. Essentially, the country in the UK, and these are two different signals from the blue line is Facebook and the red line is from a mobile phone carrier. And it's showing that the dashed line is the key, was the key stay-at-home message in the UK, which was considerably later than some comparative countries. And you can see that nearly half the drop had already occurred if you measure it by movement at that point. Okay, so that's kind of as we look now and we consider flu preparedness in the light of avian influenza, I think it is important to look back at some of those early decisions and reflect on why and how they were taken and what assumptions we might make with even simple models moving forwards. And essentially for me, I've published many charts for that about pathogens that carry such significant disease and that assume very constant levels of behavior, essentially constant betas. I think in the future I'm always going to be really careful whenever I have a scenario with a constant beta. If it's mild and vector borne, that's definitely okay. I think in lots of other circumstances, even if we don't have great science that links beta to behavior data, then I think we still need to be very careful, assuming that behavior stays the same through any period of moderate or severe disease. Just going to move a little bit more quickly now, just conscious of making sure we have some time for debates. But I want to kind of switch gears a little bit, and as we moved through the response in the UK, and we did have a really good, well-structured advisory system through SPI-M, SAGE, and then some other routes. It became obvious that the UK were willing to invest in better data. Without going into the personalities, people that I didn't know, but names that I read in the newspaper at the time, very senior advisors, were, once they realized the stakes involved in the decisions they had to make, there was a very enthusiastic attitude towards the provision of better data. And so I got involved with a group that essentially pitched the idea of having accurate community prevalence of infection, because almost all of our other metrics have unknown relationship to the number of infections, and it's actually the total number of infections at any point in time that kind of drives an awful lot of your uncertainty. Or having accurate, the hypothesis was that having accurate knowledge of the number of infections allows you to answer a lot of questions more quickly and with better precision. So I got involved in the REACT study in the UK. I'm just going to do a few slides on that. And REACT came in two flavors, REACT 1 and REACT 2. REACT 1 was using a random sample of people returning PCRs. REACT 2 was about rapid tests for antibodies. And I'm not going to speak about that today. Helen Ward led that. My main partner in crime for REACT 1 was Paul Elliott, but there was a fantastic group, many of which are mentioned on this slide. So The design was pretty simple. We invited a cross-section of the population randomly from a really nice NHS patient list. The initial design was to give each local area similar statistical power. So it's approximately the same sample size across these, what we call lower tier local authorities. It's a level 3 or a level 4 on the kind of standard classification for geographical units, and it's one of our smaller units, so 315 for a population of about 56 million. Between 100 and 180,000 took part each month, and it ran over 2 weeks, and it was approximately monthly. Initially, swabs were carried from households on a cold chain to lab for RT-PCR, and then we could do estimations of R within the 2-week snapshot, and then between snapshots, we had a really good description of a really accurate description of how the epidemic was increasing or decreasing. The individual level data allows us to look at kind of odds of infection in a very traditional epi way, and control for sociodemographic characteristics: age, gender, region, key worker status, ethnicity, household size. We've got lots and lots of results out from REACT, and there's still more to come. I think the key thing that studies like REACT and an ONS study can do is they can give a clear view of risk of infection versus risk of disease, and versus risk of reported disease. And as I say, I'm not going to cover them today, but we've got some really nice results on where it allows to separate out the sociodemographic characteristics of your local neighborhood versus your household size versus ethnicity, and to try and disentangle those at different points in time to see which of those is causing a higher risk of infection or not. And in some ethnic groups, at certain times, you get pretty good evidence that even controlling for household size and the neighborhood, the ethnicity was contributing to significantly elevated risks of infection. And as we look back and plan for the future, I think there is going to be really good value in getting as much out of these data as we can. And as I said, we were fortunate to have the resources made available. It was an absolute pleasure to work on this. We got to look at tested samples from over 2.6 million people over about 19 rounds. I think we approached 16 or 17 million people out of 56 million in the UK over the period of the pandemic. So it was a science as a scientist, it was an absolute privilege to be a part of that. And this is my as I said, my there's a large team. My main partner in crime was Paul Elliott, a fellow academic from Imperial College, who has worked some on infectious disease before, but works on a lot of traditional epidemiological studies or chronic disease epi. And Paul was a much bigger fan of tables. I was always a fan of charts, and making things look really pretty. But I do think there's a difference between getting the right answer and being able to communicate an accurate answer in a way that cuts through any other evidence that's around. So the important point I make on this chart is the absolute clarity with which you can communicate this to both senior advisors, and then for the majority of the time on REACT, I was not speaking to politicians, so I'd be communicating it to senior advisors who would then go on and use it. And also we got to communicate it to the media, as I'm sure many people on the call today did lots of engagement with the media. And that's where it became really obvious that the study design allows you to cut through a lot of the noise. You might be able to get to the same answer with a more complex design or some really sophisticated analysis to overcome biases in different data streams. But if you can say we tested this many swabs, we got this many positives between these dates, and the prevalence is increasing really quickly or it's decreasing really quickly, it wasn't a case of just having, in inverted commas, the right answer. It was being able to explain how you'd got it within a minute or two, I think was really powerful. That's a difficult thing to measure. I think of it mainly as cut through. That's an expression that was kind of developed in the UK, the ability to cut through. I don't know exactly how you measure that and how you value that, but it certainly was an important part of our experience. And it allowed us to do things like this. So this is taken from rounds 12 and 13, which was the taking off of the Delta waves. I'll just talk about some briefly about these as an example of the type of results that we could do to show how different age groups were driving transmission. There was a lot of debate all over the world about whether children were important in driving transmission. We know that we knew early on that they were either not getting infected or they were not getting disease if they were infected, and that the rate at which they were turning up as cases was very, very low compared to older age groups. And it wasn't constant throughout the pandemic. The explanation for why that was happening wasn't constant, but there was a lot of debate, certainly in the UK, about the degree to which children contributed to transmission. So being able to show in very simple terms how at times school-aged children and young adults had much higher levels of prevalence during periods of growth was really powerful. And there were considerable there were periods of the pandemic in the UK where school-aged children were really definitely driving transmission in a way that's pretty much irrefutable when they achieve very high levels of prevalence and they grow more quickly. There's pretty much no other explanation. So I think it was really useful for teasing out the difference between disease and infection in the drivers of the epidemic at different times. For what it's worth, I don't think the fact that children were capable of driving transmission necessarily means that schools had to be closed, and we did a reasonable job in a very, in lots of ways of having schools open for as much as we could in the UK. But I think even if your absolute priority is to keep schools open, you need to understand the degree to which that's costing you in transmission terms. And it means if you're thinking about it as a transmission budget, you have much less elsewhere if children are able to contribute substantially to transmission. The other during this period, the other nice thing that we could do was to look at the different outcome for vaccination. So colleagues at UKHSA did some fantastic work looking at how having a vaccination change your odds of becoming a case, or how having a vaccination change your odds of becoming an infection. But what we're able to do with the REACT study was to look at how vaccination changed your odds of becoming infected. So a measure of the vaccine's effectiveness against being infected. And even though we had a very large sample size, the way that the vaccine was rolled out in the UK meant that age and time were strongly correlated. We got really wonderful cohorting, age cohorts in the vaccination program. I think that contributed to some of the periods in the UK where we did have lower rates of excess mortality, because we got really high uptake in the most at-risk people first. But it meant that in any kind of round-to-round comparison, we were having to try and control for this strong correlation between time of vaccination and age. But even against that, between rounds 12 and 13, we got pretty clear signals of a fairly rapid drop-off in the protection of the vaccine against infection. And it wasn't, there's some sensitivity analysis included on here. These are now published in a 2022 paper in Science with Paul Elliott as the first author. And the key points here is that protection against infection was considerably lower than protection against disease, and certainly lower than protection against severe disease, and it did appear to be waning rapidly. So it was good to be able to look at that. And then the other kind of really useful and interesting component as the genomic pattern became more and more complex was that by having this kind of individual level data measured on where we obtain our positives from a random sample, not influenced, and we sequenced them all, everything that we could get a sequence for, then we could get relatively unbiased descriptions of the speed of replacement different variants. So this shows how during July every single sample was a Delta variant versus I think it was round 13 to 12, 11, 10. In round 10 we saw none, and then in round 11 I think we saw just like 1 or 2 samples in London, and I think there is and this is one of the reasons why UKHSA still has community sampling, and we still have, we still make a lot of effort with the genomics of the community samples, that that you have the opportunity to get a relatively clean sight of the dynamics of replacement. And this is still a very active kind of concern right now, although the evolutionary biology looks very much in the favor of health at the moment. And I'm certainly, I'm sure you are feeling very positive about the way that the evolution is not throwing up really, really distinct and severe strains at the moment. But our ability to rapidly assess any new variant in as unbiased way as possible is really important, so that if there is something that has a significant growth advantage, we need to be able to describe that so we can very quickly disentangle transmission advantages from severity. If anyone's interested particularly in that, I would point them to colleagues from Imperial, so Mark Bagalan and Corey and others have got a really nice preprint now in the last couple of weeks, looking across the entire of the UK pandemic up to fairly recently, using some data from React and ONS, but doing a synthesized modeling study of how transmissibility and severity changed. And it's a really nice preprint. So if you're interested in that, I'd go there. And then, just kind of very quickly, it against a background of many different data streams with temporal bias that changes, with bias that changes over time, we could give really clear measures of how prevalence was changing, both within round and between rounds. And we can kind of show that across the whole period of the epidemic. And again, just, if you when this chart is now extended to the right going into 2022, and kind of the end of the Omicron, the study does leave on a high. It goes up to 5 or 6% in the very final rounds of React. But by reliably measuring levels of infection when they were low, we were able to give pretty confident assessments of what current severity was, and then as what the kind of upper bound would be for hospital pressure as prevalence started to rise, because we knew the low infection levels that it was going down to. Okay, and this is just a little bit more detail on that, showing how we could basically track the ratio between infections and hospitalizations and infections and deaths, and show that the red and the blue line show just how effective vaccination was at bringing the proportion, making even on a log scale, showing how the number of deaths was dropping much more rapidly than the number of infections and hospitalizations as well. So the difference between the black and the red lines on here was really was illustrating essentially the success of the vaccination program, and then leading into high levels of natural infection as well. Okay, so I think just got a few comments. There may be someone coming out. I'm just on just a second. Thank you. Apologies for that. I have the car keys in my pocket. So a couple of quick discussion points. I don't know if the top bullet is necessarily true. Probably has been true for some time, but I think the use of mathematical models to understand transmission and empirical studies that are directly informed by those models is definitely firmly established. As with any other branch of science, it's got fans and critics, and it's got its strengths and weaknesses. But I think it's a really important part of the public health armory now, and I can't see any way that will change. as much as we've done many complex models and all kinds of incredible analyses, I would say that like relatively simple models can still make important points. And I think, you know, as we go back and as we look at some of the big questions around future preparedness plans, we probably will need to go back to some fairly straightforward models and think about different objectives that governments might have, or constraints in the light of decisions that were taken and attitudes that were taken during the COVID-19 pandemic. There's obviously a massive research agenda for infectious disease dynamics that I think you know, lots of us could rattle through. My interests are certainly around behavior, the degree to which it's predictable, measurable, and can be kind of hard linked into properties of the pathogen, or can be linked to communication campaigns, essentially to try and define those links between levers and changes in transmissibility. The immunity that is becoming very complex now. It's in terms of an immune landscape, it looks much more like influenza now than it does the early stages of SARS, in terms of people having exposure to quite a number of different strains. It seems that the protection of the vaccine against severe disease is being maintained and has got reasonable longevity, and that natural infection is certainly topping up that. So hopefully from the health point of view, a really detailed understanding of the complex immunity isn't a massive deal. But if there is some really significant evolutionary event in terms of severity, it's going to be, it could very quickly become important to understand those complex immune patterns that are now developing for SARS-CoV-2. Economic sectors, so there's quite a few colleagues are looking at this, and I think in terms of the countries that get really good pandemic plans going forward are going to understand exactly how transmissibility for different types of pathogen is linked across the different parts of their economy, and how to really efficiently intervene and mitigate during any kind of similar event. And then there's loads. I'm sure you can think of your own favorite topics and lots of other ones as well. I think it's a really, I don't know the appetite that there is in Canada and the appetite for funding and really getting into the basic science and really figuring these things out. Obviously I have a huge appetite for it, but I think it's an open question, the degree to which we can make our case in the research agenda, in a shrunken research agenda, whether there is the sense that a huge amount of resource has already been put into our understanding of infectious disease. So even though the time is ripe to make huge amounts of progress and capitalize on this recent experience, it feels like a difficult time. I am going to leave it there. I have talked a bit longer than I thought that I might. I'm happy to make a few more comments about UKHSA and my role there and what we're trying to do, but I think I'd really like to just hear any comments from the audience if people have got any thoughts, and kind of stop talking into the camera for a second, if that's okay.
Thank you very much for your talk, Stephen. And anybody who has any questions, just type them into the chat or click the raise your hand button, and we'll get going. I suppose I have a simple question for you. Do you feel like the government in the United Kingdom generally followed the guidelines that you had, or that you wanted to push forward?
So it's I think so there's a lot of hopefully you probably don't have to follow the British press. There's a lot of coverage in the British press at the moment because the health secretary during the majority of the pandemic has allowed his WhatsApp account to be obtained by one of the newspapers. So right now we're getting an awful lot of WhatsApp messages that appear to show the government was not necessarily listening to all of the advice according to these WhatsApp messages, but they're slightly contrived. I think that by and large, especially after the initial early stage, I think the science was listened to. I think there are going to be some clear examples, and as I say, you can look at news stories in the last few days in the UK, where it kind of wasn't listened to very well, or to the other factors were clearly coming into play. I would say that science can't ever be the only factor in some of these decisions, and we wouldn't want it to be. So all the very difficult decisions had really substantial consequences in non-health domains, or in non-infectious disease health, and I think it was an impossible ask to have single studies that would synthesize all of those impacts and give you a trade-off. The idea of a really well-defined cost-benefit analysis for some of these decisions in the time frame that we had was just, I don't think it was plausible. And that's an active topic for investigation now. So a lot of the time we were listened to, and we wouldn't want science to be the only decision, but there are certainly times where where I think that we weren't listened to that well, and hopefully the inquiry and the lessons learned will go through and systematically identify the good examples and the bad examples.
Okay, thank you. Mortaza, you raised your hand, but then put it down. Wasn't sure if you still had a question.
Yeah, thank you for your presentation. I have no question, but I have comment about the economic sectors in this model. Regarding the economic aspect, to bring the economic sectors, we need the multi-sector economic models. Multi-sector economic models are computable general equilibrium models, which are forward-looking models. That these models are not capable to integrate those dynamic aspects in short period of time. Most of them are long time models, but we have DSU models, and DSU models, dynamic stochastic general models, which are single sector macroeconomic models, are capable to integrate the diffusion or the transmission models. And yeah, we are working at York University and fields on this model as well.
Good, great. Thanks for the comment. Good to hear. I think David Hoare, who's a former colleague of mine, now working with Katarina Hauk at Imperial, they're also looking. I'm not sure exactly which models they're using, but I think that they're looking at multi-sector models and trying to integrate the disease dynamics with the economic impact. And I think it's an area where we don't necessarily need, I made comments about how it's very difficult to accurately capture the temporal trend because of behavior change. And unless you get the behavior change right, you're not going to get the temporal trend correct. But that's not necessarily the only important thing. When you're looking at the economic trade-offs, you want to get the relative impact across the sectors on both transmission and some measure of productivity. You want to get those relative measures really as accurate as you can. So I think there is, I think it's an interesting and tractable set of questions there.
Thank you.
And Martin Grotto?
Yeah, I was just wondering, because the fact that all the more senior people in the field than me have kind of pointed out that there was an uptake in funding after SARS-1 and swine flu, and after a few years it quickly dropped off. How much do you worry about that happening with as a result of COVID, and how much do you think that's likely to occur, or what we could do as a community and group to prevent that from happening?
Yeah, good question. I think I've never seen a study of the cycles, the seasonality and periodicity of funding. Maybe there's an El Nino effect, but I think we would expect there to be cycles and for the major emergencies to drive that. I think that probably the degree to which we can focus on the best long-term questions. So it's, infectious disease dynamics doesn't feel like a fundamental science. It doesn't feel like you're proving relationships that hold for all time. A lot of what we do, a lot of what we did in React was looking at, week to week and trying to really clearly identify some patterns. We could explain them pretty quickly and then they pass. It's quite transient. But I think as we move out of the immediate public health crisis with lots of very, very difficult decisions, I think it's, as a community, it's trying to figure out those more fundamental questions. And it's not just about the math, it's not just about the models, it's about what are the types of data that we could collect. So can we validate really good behavior data that does allow us to improve our forecastability for respiratory viruses and things like that? I think that we can mitigate the risk by doing the best job possible of identifying fundamental questions. You've definitely got to counter the idea that funders know the right questions. So that's the first thing. I think funders have a really good idea and they're great people, but we've got to try and make sure we're answering the longer term questions. And then as the value from those becomes more and more clear, then we establish ourselves as more of a stable long term rather than a kind of reactive or emergency driven community.
Okay, Thomas.
Hi, great talk, by the way. I wanted to ask a bit of a sort of ethical question, which is, so when you're weighing up, the cost of, the impact on the economy of, shutting down businesses and forcing people to stay indoors, and whether you put a sort of monetary value on the sort of social impact of not locking down, when that, whether that be, the impact on the NHS or the monetary value of people's lives being lost, if that makes any sense.
It does. And I think, there's a lot of work to be done figuring out what the right framework is to weigh those things against each other. I think in the very early days, there was and in the narrative in the UK, there's still a false narrative that there was a choice between massive changes in society because of a government decision versus some very rapid wave and then a return to normal life. That choice was never there. So I think it was, and then trying to define the counterfactual, what would have happened if other decisions had taken, was very, very difficult. And to some extent, that the inability to define the counterfactual is a much bigger quantitative issue than being able to assign costs to what would have happened in that counterfactual. So I don't think we were in a position to do it at the time. I think that if we would have been, we certainly would have. And there's a lot of active research now. We did some work. Mike Tilsley, Matt Keeling, and others did lead some work that's been published, really trying to look at this in terms of GDP through some of those different decisions through the autumn of 2020. Autumn 2020, I think, was the kind of context that we looked at it in. But it's very difficult to assign those costs. And as I said, unless you get an epidemiological counterfactual that people agree on, then that dominates everything else. I hope that helps. I was slightly wondering, but I hope those were useful comments.
Yeah, I was going to add one other question in regards to the general advances in vaccine technology. Like, this is the first mRNA vaccine that's been relatively developed and quickly, considering the pandemic and its size. Are you optimistic over this general technology and its use in future epidemics?
Yeah, I am. I'm not very close to this. I understand it's being reported that more than one company is looking at flu versions of the mRNA vaccine. Scott Hensley and his lab had a paper in Science looking at highly valent mRNA vaccines against flu, essentially a universal flu vaccine just through being highly valent. Derek Smith's thought about that a lot in the past as well. And the other thing is and I'd love if someone on the call has got much better recent information on this. It's not that the properties of the vaccine in terms of not being transmission blocking and waning quickly may be features of the proteins, the antigens. They may not be down to the vaccine technology at all. So it's possible for something like flu that it would be both quicker to make and have much better potentially transmission blocking and perhaps not as bad waning. So I don't think we know yet whether it is, but it certainly for flu preparedness, even though we have to base our thinking on currently approved technology and we have to think about pre-purchase agreements for reactive traditional flu vaccines, I think if there was a really, even if there was a new pandemic tomorrow that took off, I think a lot of the debate would be very quickly around mRNA because of the precision with which you can make the antigenic component and the potential speed of manufacture. I think there's a lot of global equity issues around mRNA vaccine. And I found it very frustrating that we couldn't prioritize globally from the point of production. The constant kind of recourse to stockpiles and deliveries at some future time point, so that this many doses will be sent to resource poor countries, but not when they'll be sent there. I found that very frustrating, and I think in any kind of future scenario, we need to organize ourselves and look at prioritization of things as they come off production. And that's the only way that we will get. And be honest, we're going to serve ourselves first, probably to some degree, or with some benefit or some bias towards countries. Our politicians are elected to look after us, but be really upfront and say how much are we going to give and when are we going to give it based on the production.
All right. So any last questions for Dr. Riley? Doesn't look so. But anyway, thank you very much for the talk, and it was a pleasure.